Hello, everyone. This will be our lecture on antibiotics. It's recorded for you to look at as many times as you think you need to. It may actually be in a couple of installments as we can only go 12 to 14 minutes at a time. But here we go. We're going to talk about antibiotics. So basically, and you can read the definition here, it's medication to treat bacterial infections. Ideally, the suspected areas of infection should be cultured because when you do a culture, it tells you what type of organism it is. And as you will see in the next several moments here, that there are many types of different antibiotics in different groups and because they're used for different things. So we need to know what the organism is, and we do that through a culture. Empiric therapy and prophylactic, we've talked about a little bit, but I'm going to go over it again because we are talking about antibiotics. Empiric therapy is the treatment of an infection before the culture results have been reported or obtained. It's just because the patient may be very, very sick and we're not going to wait 24, 48, 72 hours, however long it takes for the culture to come back. We need to start treating this patient with something. And then prophylactic therapy is any time we treat with antibiotics to prevent an infection. They don't have one, but now we're going to prevent it. A lot of times for intra-abdominal surgery, they'll go ahead and give them a dose of antibiotics prior to the surgery, and then following trauma too is another very, very common. Therapeutic response, we've talked a little bit about that too, and basically in very simple terms, it's the response we want. It's the response we want to see from the patient. It's where signs of infection have diminished. When they have come in with a fever, therapeutic response is now we have a diminished fever. It may not totally be gone, but now it might have gone from 104 to 102 or 102 to 100. Decreasing white blood count. We've learned over and over that elevated white blood count is a sign of an infection. So now we're going to see it come down. Normal white count is 5 to 10,000. Usually it's way over 10,000 to be an infection. Redness, swelling, drainage, all signs of an infection, and pain will be diminished if we get a therapeutic response. A sub-therapeutic response, it's the signs of infections just don't improve. So meaning it's sub-therapy. It's just not working. Elevated temperature may persist, increasing white count, or it's just coming down a little bit, or maybe going up. Redness, swelling, drainage, and pain increases or persists. Actions of antibiotics. We've got bactericidal or bacteriostatic. Cidal, we know, usually means kill. So cidal is going to be the stronger bacteria, the stronger, well, they will be stronger bacteria too if they kill. But stronger bacteria, and it means this antibiotic is a little bit stronger because it's not going to just keep the bacteria at bay, it's going to kill it. Bacteriostatic, it inhibits the growth. So hopefully we can get rid of it also, stops the growth of the susceptible bacteria rather than killing them instantly. Will eventually lead to bacterial death if we make sure we inhibit that growth enough. I wanted to talk about, before we actually move away from this slide, what narrow spectrum antibiotics and broad spectrum antibiotics means. Narrow is just what it says. It's they're only the antibiotic is only active against a very few or a narrow margin of microorganisms. Where broad spectrum antibiotics, it's active against a whole wide array of microbes. It may even both include gram-negative and gram-positive microbes, which I know you learned about in microbiology. Combinations of antibiotics generally needs to be avoided. We don't want to do it. We know that we've overused antibiotics to the point where some of them don't work anymore. Exceptions include initial treatment of very severe infections such as sepsis, infection with more than one organism. Well, you may need a couple antibiotics. Treatment of TB, tuberculosis, and we've used basically the same 4 groups of drugs for the last 50 years, and they work. The efficacy has been proven over and over, so we keep those in combinations. And then treatment of infection in which combination therapy can generally enhance antimicrobial effects. Oh, also initial treatment of severe infection, sometimes with a neutropenic patient. A neutropenia, neutrophils are very baby early white blood cells. They're the young white blood cells. And when cancer patients are on chemotherapy, it wipes them out. So we say they're neutropenic because they have less than the right amount of neutrophils on board. And so because of that, they're more prone, because we know our white blood cells are our fighters. So they're more prone to infection. So a lot of times we may be using combinations for those folks. Infection with more than one organism. And some examples of that would be in brain abscesses, pelvic infections such as pelvic inflammatory disease, any perforation of an organ, such as like what if an appendix bursts? We know sometimes that can hold some really bad stuff. We don't want it to get into the bloodstream. So they will use combinations there. A prophylactic, again, is prior to, and we're trying to keep them, to prevent them from getting an infection. Certain surgeries, again, neutropenia, I just explained that. Recurrent UTIs. Now, why do you think recurrent UTIs is a urinary tract infection? Why? Why would we be so wanting to prevent those? Well, if you follow the urinary tract infection up that tree, it can go to a kidney, right? Yes, very, very severe infection then. And then patients at risk of bacterial endocarditis would be patients with the prosthetic heart valves or congenital heart disease, because we don't want to have the heart to get infected. And then I want you to think about this. This is one of the questions I want you to bring back with you for misuse of antimicrobial drugs, attempted treatment of untreatable infections, and fever of unknown origin. Why? Why do you suppose we don't want to treat those? And what can be an untreatable infection? What do you think? What kind of infections can be untreatable? What would we classify those as? I'm going to leave you with that thought and see what you come up with for me. Okay, moving right along to our very first group of drugs, the sulfas, or sulfonamides. It was actually the very first antibiotic created in very, very late 1800s, early 1900s. First class of antibiotics, sulfadiazine, sulfamethoxazole, sulfazoxazole. A lot of the sulfas end in azole, but not all of them. And most of them have SULF in it somewhere, so that can help you try to remember them when you're first starting out. Mechanism of action, how do they work? Well, they're bacteriostatic, and we've already learned that bacteriostatic is where it's going to inhibit the bacterial synthesis. So it's a little slower kill of the drug. It's not cidal, it's static. And how it does is it prevents the synthesis of folic acid required for synthesis of purines and nucleic acids that inhibit bacterial synthesis. That's how basically it prevents the synthesis of folic acid. Indications are for primary urinary tract infections caused by susceptible strains. Enterobacter, E. coli is usually the most common character for causing urinary tract infections, just because we find it so much in the rectal area and it's at close proximity, especially in women, and it's more common in women, urinary tract infections. And you can see the rest, Klebsiella, both Proteases, and then Staph aureus. And here it is. E. coli, most common cause of uncomplicated UTI. Trimethoprim or sulfamethoxazole is a treatment for choice for oral therapy of urinary tract infection. Urinary tract antiseptics are second choice drugs for UTIs, and all that means antiseptic, it's going to help you not feel such cramping if you have that in the bladder area. It's an antiseptic. It's just going to, almost they use these as pain, not so much as an antibiotic. So nitrofurantoin is one, methanamine, nalixic acid, and cyanoacid. Sulfonamides continued. We've got our pneumocystis pneumonia, upper respiratory infections. They use sulfonamides in combination. As you can see, I've got listed here. The generic would be trimethoprim and sulfamethoxazole, which is Bactrim and Sulfa. Remember we talked about those, the generic, which is the trade name, and there's only one name, and those are always the harder names, and because they reflect the chemical composition. So the trimethoprim and the sulfamethoxazole are the generic names. The ones in parentheses are going to be the trade names, and you can see Bactrim and Sulfa, much easier to say, right? So therefore much easier to market. Used for urinary tract infections, otitis media, which is just middle ear infections. And then we have erythromycin and sulfazoxazole, and that's referred to as pediazole. And pediazole is a sulfa, used to treat with little kids a lot, middle ear infections. And then gantricin, used to treat middle ear infections, UTIs, and other conditions. So you can kind of see even the different groups of sulfas within sulfa group. What are we treating? We're treating middle ear infections, and we're treating urinary tract infections. Adverse effects. Now we talked about those. Those are not effects that we want to see in people. And so for sulfas in the blood, we have hemolytic and aplastic anemias, agranulocytosis, thrombocytopenia, which would be lacking blood clotting factors in the blood. For our skin, integumentary, photosensitivity. That means they're very, very, very sensitive to the light, even with sunglasses on. Exfoliative dermatitis, where our skin's literally coming off. Stevens-Johnson syndrome can be painful red, purplish rash that blisters and causes skin to shed, to come off. And epidermal necrolysis. Again, lysis is anything that's tearing something down. Gastrointestinal, nausea, vomiting, diarrhea. And I'm telling you right now, you could always say nausea, vomiting, diarrhea when you're talking about antibiotics. If that's on there, choose it. Pancreatitis, convulsions. So you can see it's simple sulfa. It's a bacteriostatic antibiotic, but look at what can happen. Sulfonamide's another thing that we need to remember, should be taken with at least 2,000 cc's of fluid per day unless contraindicated. So when we're doing our patient education with sulfa, they have to push the water. Oral form should be taken with food or milk to reduce that nausea and vomiting that they may get with the sulfas. Okay, I'm going to stop right now, and we'll go on with the penicillins after the next time I talk.